है जात धर्म क्या, सभी का ख्याल रखते हो। बस लक्ष्य है सेवा, सेवा से कभी ना थकते हो। नहीं जान की परवाह, निकले हो जान बचाने को। तुम रोक ही लोगे आंधी जो है आने को। शुक्रिया भारत के योद्धाओं, एम्प्योर करे सलाम आपको। शुक्रिया भारत के योद्धाओं, एम्प्योर करे सलाम आपको। कैसी ये जंग है, पड़ी मौत सांसों के पीछे। बने तुम जो मसीहा, जगी जिंदगी में उम्मीदें। वहाँ वीर खड़े हैं उन सरहदों की रक्षा में। यहाँ आप डटे हैं इंडिया की सुरक्षा में। शुक्रिया भारत के योद्धाओं, एम्प्योर करे सलाम आपको। शुक्रिया भारत के योद्धाओं, एम्प्योर करे सलाम आपको। एम्प्योर करे सलाम आपको।
Hello everyone, I am Dr. Komal Chavan, Chairperson, Foxy Medical Disorders in Pregnancy Committee, and I welcome you all to this webinar on hematological disorders in pregnancy, which is the most commonest medical disorder which we see during our pregnant patients. And to give us the more seek for knowledge and the information, we have stalwarts, an eminent speaker and panelist. So we have Dr. Abhay Bhave, who is a hematologist, and our very own faculty member, Dr. Suchitra Pandit, Dr. Shanta Kumari, Dr. Pratima Mittal, Dr. Saraugi, who all will be there to answer all your questions and give us more information about this much sorted topic. To moderate, we have Dr. Niranjan Chavan. He is Vice President, Mumbai Obstetrics and Gynec Society. He is the Secretary General of Maharashtra chapter of IAG. He is Professor and Unit Chief at LTMMG Sion Hospital since last 23 years and have been a medical teacher and teaching all the students and conducting a lot of courses. That is the basic infertility care, then the endoscopic courses, and he's also the national coordinator for the Foxy Medical Disorders in Pregnancy Committee. So, without a delay, I would hand over to Dr. Niranjan Chavan to moderate and welcome and introduce our speaker and the panelists. Thank you very much. And also, before that, I would just like to thank Impure for that wonderful video, what they said at the beginning. Team Science Integra and TOG, thank you for bringing us together on this platform. Thank you very much. Over to you, Dr. Niranjan Chavan.
Thank you, Dr. Komal Chavan, the chairperson of Foxy Medical Disorders in Pregnancy. I would also like to thank Dr. Alpesh Gandhi, our president of Foxy, and Secretary General Dr. Jaideep Tank and Dr. Alpesh Gandhi's vice president, Dr. Atul Ganatra, West Zone, to be associated with us. It's a privilege and honor that today we are hosting world renowned, I can say that. It's Dr. Abhay Bhave, a great hematologist who is with us, and he is attached to Leelavati Hospital and Research Center, a very soft-spoken, down-to-earth person. He has been attached as a member of the task force for the national guidelines for myelodysplastic syndrome and also of the deep vein thrombosis. He's got many international and national publications, and he is the chairperson of Lions Club of Mumbai, Carter Road for Cancer Detection and Treatment, and also of Ekta Manch. He has been a member for the newer anticoagulants guidelines and member for the Board of Studies IMA Mumbai West. Welcome, Dr. Abhay Bhave.
Thank you very much.
I would like to also welcome now our panelist, our esteemed panelist, and we have none other than Dr. Suchitra N. Pandit. She's an MD, DNB, FRCOG, FICOG. We all know very well that she's an academician. She was a professor at Sion Hospital where she served for more than 20 years. Then she went into her private practice. Presently, she is attached at Surya Group of Hospitals in Khar, Mumbai. And we all know that she was also the Foxy MOGS president, and currently she is the chairperson of AICC RCOG 2017-2021, president of ISOPAP 2018 and 20. She has been a very important figure in pioneering the Foxy Youth Mela, and she has organized and reached nook and corner of India. She's got many publications to her credit, and has given more than 35 orations up till now. And she's very popular in Mumbai city for her programs of Kishori Adolescent Empowerment Project, which I was also a witness, where she carried out in the largest slum of Asia, that is Dharavi. Thank you, Dr. Suchitra Pandit, to join with us. Now, we welcome Dr. Shanta Kumari, the Iron Lady of India, our President-elect of 2021. She is the consultant at the Yashoda Hospital, Hyderabad, and we all know popularly she is very well known for her various conferences which she has done for last 15 years, namely the AICOG 2011, the ICI 2012, Foxy Figo, and there are various conferences, but more importantly, she is on the working as a working member in the Figo Violence. Shankumari, please welcome. Thank you. Then we have from North Zone, our own Vice President of Foxy, none other than Dr. Pratima Mittal, Madam. She's a professor and consultant at VMMMC Safdarjung Hospital, honorary FRCOG, head of the department, former of VMCC Safdarjung Hospital, and she was also the president of Obstetric and Gynec of Delhi. She has got various projects and various papers on her name published in the national and the international journal, and she has been more popularly known because of her collaboration with WHO projects. Thank you, Madam, for joining us today on this wonderful webinar. Then we have the Guru of Gurus, Dr. Rajendra M. Saraugi. We all know he has been for many of our organizations, namely MOGS and AFG. He was the honorary professor at State GS Medical College and the head of the department of the Dr. R.N. Cooper Hospital. Presently, he is the president of the Society of Vaginal Surgeons of India, that is of the Maharashtra chapter. He has been an undergraduate teacher for more than, has written various books on various topics. We welcome Dr. Saraugi for his expert opinion and as a panelist today after a lecture of Dr. Abhay Bhave. So I would like to tell you all that inherited hemoglobin disorders were originally characteristics of the tropics and the subtropics, but are now common worldwide due to the migration which is occurring. And the diversity and the heterogeneous distribution of hemoglobin disorders makes it necessary to develop strategies at country level, and that is the reason we have thought that today we should have this topic, hematological disorders in pregnancy. And I want to tell at the beginning, the users which are logged in has begin with more than 2,000 delegates, and I am really thankful to each one of you. You are those people who keep us on and make us feel to be connected with you through science, Integra, TOG webinars. So please do subscribe. If you have missed any of those webinars, not to worry. Just go on YouTube channel, type Science Integra, and you will see all the episodes of the webinar. So guys, I'm not going to be there for more time, and I present to you none other than Dr. Abhay Bhave, who is going to talk on thrombocytopenia in pregnancy. Welcome, Dr. Abhay Bhave.
Good evening, everybody. First of all, Dr. Niranjan Chavan and Dr. Komal Chavan, thank you very much for the kind introduction. I'm just going to share my screen with you, if I can.
Yes, sir, we can see you. We can see your sharing of the screen. Sir, you can press the slideshow and from the current slide. So it will be started.
Yeah.
Thank you.
It just refuses.
Sir, please press from the beginning, then it will start.
Yeah.
It's on the left hand side. Left hand side.
It refuses to come up. 1 second. Yeah. Can you see it now?
Yes, sir. Yes.
You can see it now?
Yes, sir. But you will have to have a slideshow which starts from the beginning. We can see you, sir.
Let me just try to get it on.
Yeah.
I'll have to restart. Just hold on. Huh? I'll just restart.
Yes, sir. So as I said today, hematological disorders in pregnancy has got many disorders. It's not only iron deficiency or megaloblastic anemia. It could be dimorphic anemia. And we have also various types of hematological disorders like sickle cell, thalassemias. And today we have got Dr. Abhay Bhave, world-renowned hematologist.
Can you see it now?
On thrombocytopenia in pregnancy. Please start, sir.
Can you see it now?
Yes. Please go ahead, sir.
Okay. So, Dr. Chavan and Dr. Komal Chavan, thank you very much for the kind introduction. I don't know whether I'm worthy of it, but I'll see whether I can make a difference to this discussion. I'll first of all thank the Foxy Medical Disorders in Pregnancy Committee for the opportunity to discuss with you thrombocytopenia in pregnancy in today's webinar, which is dedicated to hematological problems in pregnancy. You'll see in this slide that when we talk of thrombocytopenia in pregnancy, it's actually a maze of events that are there in pregnancy which can contribute to thrombocytopenia. So we can have from spurious reasons to reasons which are gestational, which occur only during pregnancy, or we can have it as part of macroplatelet syndrome, as part of preeclampsia or hypertensive disorders, as part of ITP, as part of the dreaded microangiopathy, one of which is of course the DIC. All these have different connotations, have to be diagnosed properly, and all their treatments are different. I'm now going to be talking on the infective causes of thrombocytopenia, which contribute to about 1 to 2% of the thrombocytopenia in pregnancy, such as malaria, typhoid, dengue, and now the COVID. They don't come in the ambit of today's discussion. So if you see how to view thrombocytopenia in pregnancy, I think there are a few things that we have to do. Look at first an automated CBC report and look at all the 3 indices. The hemoglobin, WBC, platelets, all have to be looked at before we say that it's an isolated thrombocytopenia. Then look at the indices also, because sometimes there may be an associated anemia, which is very common in pregnancy, and the indices may help you to decide whether there is something other than just a thrombocytopenia. If there is just an isolated thrombocytopenia, then usually it is going to be a primary immune thrombocytopenia or a gestational thrombocytopenia. However, if the thrombocytopenia is associated with an anemia other than the iron deficiency or thalassemia, or bleeding events, then you have to start looking for unholy connections of these cytopenias. Let me give you some home truths about thrombocytopenia in pregnancy. Thrombocytopenia is defined as a platelet count less than 150,000. Normal is 150 to 400. And this is the second most commonest disorder in pregnancy that we see.
Hello.
The commonest being anemia. Usually the thrombocytopenia is about less than about 10%, between 6 and 11% during pregnancy. And many times it starts from pregnancy and then gets deeper as we go along. Usually platelet count of 100,000, which is the worry, is observed in only 1% of pregnant patients. So I think most of us can breathe easy. However, our task is to find out what is the pathophysiologic nature of the thrombocytopenia and the risk to both the mother and fetus as part of the thrombocytopenia, where of course we try to first take care of the mother and then if it's possible the fetus. The reason why we want to know the pathophysiology is because our treatment goals in the management of this dynamic state of parturition depends a lot upon what is the cause of the thrombocytopenia. And our thoughts, our therapy, our interventions, particularly during the delivery, will keep changing. So the target keeps changing based on what is the pathophysiology and how is the trend of the platelets in the patient. Especially during delivery, when there is a surgical risk of the delivery, especially for the neonate's passage through the birth canal, we have to keep a watch as to whether a vaginal delivery is allowed or whether we have to go in for an intervention like a cesarean section. The diagnostic distinction among the potential etiologies for thrombocytopenia is therefore extremely important for correct management. Let me tell you, 70% of the times, this thrombocytopenia will not be associated with the pathology. It will be just gestational and you won't have to do anything for it. The moment the platelet starts going below 100,000, we start to keep our antennas alert. Usually bleeding does not take place till the platelet count has come to somewhere around 50,000. This is if you are going to do any interventions. But spontaneous clinical bleeding is very rare unless the platelet count is less than 20, especially 10,000. Now the basic thing in thrombocytopenia is that it can either be because of production, lack of production or excess destruction, or because of consumption. It could also be that there is utilization of the platelets as part of an infective process. We are not going to discuss these infective processes. But it's important to take a good history so that we know whether we are dealing with an infective cause or not. However, when as a hematologist, I am referred to thrombocytopenia, for us to happen. Let's go to gestational thrombocytopenia. Gestational thrombocytopenia is a situation which is seen in about 5 to 10% of patients. It is usually dilutional. It is because of a little bit of thrombin generation. As you know, pregnancy is a prothrombotic state. And sometimes there is destruction of the platelets on the scar trophoblast surface. Gestational thrombocytopenia is more a diagnosis of exclusion. Usually the platelets are normal and they start reducing by about the second or third trimester. Usually they do not go below 100,000, but in literature is reported up to 70,000 platelet count as the one where we have seen it to be still gestational with no other reason. Normally they are asymptomatic and therefore no treatment is needed, and we just have to observe such patients. What happens to them post-delivery? Usually the platelet count rises and comes back to its normal state. And the fetus is fine and usually does not exhibit any thrombocytopenia. The situation changes a little bit when it comes to immune thrombocytopenia. In immune thrombocytopenia, which is thankfully seen in about 3 to 5% of cases, there could be either asymptomatic or symptomatic with bleeding events or mucosal bleeding events or skin purpura. And it's quite possible that during pregnancy, this thrombocytopenia of immune nature may worsen. Usually the platelet count is low at the time of diagnosis, at the time of pregnancy. And then based on what is the nature of the immune process and how rapid it is, that means production destruction balance, the drop in platelet count may be either slow towards third trimester, more rapid towards the second trimester, or very rapid in the first trimester itself. And the rate of drop would also depend upon not only the immune status, but what is the beginning platelet count. And therefore, it's very important that when an ITP girl is considering pregnancy, we should counsel her properly to see that she's the right candidate for undergoing a pregnancy in her platelet state. The lower the platelet, the more is going to drop. Sometimes we've seen that the platelets are low and they just remain low throughout pregnancy. They don't budge because the net production and destruction match each other. And that's why sometimes we don't even have to intervene. So we've seen all kinds of behaviors in immune-mediated thrombocytopenia in our patients. However, the moment the platelets start coming to 30,000, we start getting a little bit anxious. Till 30,000, we just like to observe the patient, look at clinical details, and see the rapid rate at which the platelets are dropping. If they are not rapid, we would prefer to observe. However, if the platelets are now dropping below 30,000, then we have to go by clinical decisions. So if the patient's platelets are dropping rapidly, we can intervene with certain products such as intravenous immunoglobulin or steroids, and very rarely platelet transfusion only if there is bleeding. Normally we avoid platelet transfusion. Immunoglobulin is expensive and our country cannot afford for every single patient. However, it's the most rapid and fastest method to increase the platelet count without exposing the young girl to steroids. If the drop in platelets have occurred very early in pregnancy, like in the first or second trimester, then we have to support her to the third trimester and beyond till her delivery. Then maybe immunoglobulins can be given and a trial will show us whether there is an increase in the platelets or not. The big advantage is that once the platelets rise, they might last us for a period of 3 to 6 weeks. However, they could drop again, needing this immunoglobulin again and again, which makes it again a very expensive option, but it's a very safe option. Why am I saying safe? Because steroids, although they bring up the platelets in immune thrombocytopenia, they come with a baggage of causing a lot of side effects. So prednisolone at 10 to 20 milligram per day can be started off in such patients, but it can early in pregnancy can affect the child in terms of making the child big for date, and in the future the child can also become diabetic. And therefore such patients who take long-term steroids during pregnancy can end up having a problem of normal vaginal delivery, and they'll end up need to have an LSCS because of the size. Platelet transfusions only care for those patients who are bleeding. What happens to them subsequently? Usually ITP platelets, they go back to what it was to begin with. Sometimes they are lower, and they can be then treated with medications such as TPO mimetics. We've got now L-Thrombopag, we've got Romiplastim available in the market, which can be used once she has delivered. These agents are not approved when in pregnancy, but postpartum we can use them. What is the effect on the fetus? The fetus can have low platelets as part of a neonatal alloimmune thrombocytopenia, and therefore please don't forget to do the child's platelet count. And we have given immunoglobulin to the child to bring up the platelets if the platelets are very low. This is about immune thrombocytopenia. The hypertensive disorders are something that you and I work together for, and we pick them up. Its incidence of causing thrombocytopenia is about 20%. Preeclampsia taking away the chunk about 5 to 8%. It will be defined when the systolic blood pressure has remained consistently high above 140 and diastolic above 90, and there is a proteinuria. Please remember, thrombocytopenia may be the first manifestation of a hypertensive disorder such as preeclampsia, and if your patient starts developing thrombocytopenia which was otherwise in the normal range, then please do a protein check the blood pressure, and you might be facing with a preeclamptic state. Generally, the diagnosis is made where we have to be aware. We have to keep a watch on the blood pressure, and we are doing CBCs regularly. From the experience worldwide, platelets are usually normal, start dropping around the 20th week, and the manifestation of preeclampsia usually for thrombocytopenia around the 20th week. But it can occur anytime, even up to postpartum. Therefore, again, awareness and management of blood pressure and a trend of CBC is very important. There's another hypertensive disorder by the name of HELP syndrome, which can also occur along with the preeclampsia and can be a sequel to the preeclampsia. And that can also occur towards about the third trimester, and that is hemolysis with elevated liver enzymes and low platelets. But that can also occur in the postpartum phase. Then there's a dreaded acute fatty liver of pregnancy, which is another hypertensive disorder which can occur around the third trimester. So all these three can come in the second or third trimester in the hypertensive disorders. So the thrombocytopenia occurring in the second and third trimester, please be wary. They could augur poor or unwell for the patient, and we have to be very careful that we are able to pick them up, because acute fatty liver pregnancy comes with abnormal coagulation, abnormal liver function test, and a high bleeding risk. We will talk about the management soon. Once this has been diagnosed and effectively managed, then usually postpartum, the platelets start returning to normal by about the day 6 in most of the cases. However, it can be dangerous to the mother, especially to the fetus, and most of the time we'll end up having to either support them for a short period of time and then take them up for delivery. What is the effect on fetus? All of these can also cause the fetus to be low, but most importantly, all the three of them can make you deliver the child even before it is mature. And that's one of the big worries that we have in the hypertensive disorders of thrombocytopenia in pregnancy. So this slide is showing that one of the worries that we have with the HELLP syndrome, which is the hemolysis with elevated liver enzymes and low platelets, where the maternal mortality can be as much as 3.3%, the perinatal mortality can be 22%, and that's because of the various hematological problems of abruptio, placenta, etc., which can occur during the HELLP in patients with thrombocytopenia. There is another dreaded one, which is called TTP and HUS. But then let me tell you before that if a patient of preeclampsia is going to HELLP, can you be able to pick it up earlier? And there is one answer, and that is ADAM-TS13. ADAM-TS13 is a test which can be done. Unfortunately, it's not universally available, but it can be done in order to pick up a patient going to from preeclampsia to HELLP syndrome. ADAM-TS13, if the level starts dropping below 30%, we know we are heading towards trouble and that we may be going on to a HELLP syndrome. Beyond the HELLP syndrome and the AFLP is TTP and HUS. These are microangiopathic disorders which occur either mid-trimester or later in the trimester, and HUS usually occurs postpartum. And generally, they can be associated with stillbirths in 40% of patients. So picking up this thrombocytopenia is very important. I showed you the slide of a schistocyte. That's what we see in the peripheral smear, which helps us to pick up the diagnosis of TTP. It is associated with a high mortality for the mother, and that's why it's extremely important that we diagnose it right in time. And please remember, TTP doesn't mean deliver immediately as we think in HELLP and in AFLP. Here we first want to save the mother. We are not interested in the child in that sense. We will do plasmapheresis, stabilize the mother, and then deliver the child. We can try to take it as much to term as possible. Once we do plasmapheresis, we're able to salvage the situation. If the platelets start rising, then once they go above 50, we start giving low molecular weight heparin, because these platelets are very sticky and they cause thrombotic thrombocytopenic purpura. They cause clots. And placental clots can prevent the growth of the child. And that's why once the platelets are above 50,000, we put them straight to low molecular weight heparin and see that the flow to the child is good, and we monitor them with Dopplers. HUS usually in pregnancy is not that one which you see with diarrhea seen in children. It's an atypical HUS which is complement mediated. There is a drug called eculizumab, extremely expensive, but it can be used to manage the patient. We don't have it readily and easily available in India. Generally, HUS, if we can manage it, we manage them with plasma infusions and dialysis as much as possible and try to take the baby as much to term as will allow. Otherwise, we have to deliver the child. One of the most vicious parts of thrombocytopenia and thrombotic microangiopathies in pregnancy is the one which is related to disseminated intravascular coagulation. Here there's an unholy mix of infection, inflammation, coagulation disorders with rapid inflammation and consumption of components causing endothelial dysfunction, ischemia, and organ failure. Maternal mortality is high, something which we all dread. And therefore, if you have clinical evidence of bleeding in the lady, she's unwell, she's multiple organs are involved where her blood pressure is getting lower, or she's got a urine output which is decreasing, or she's got bleeding at the sites of blood collection, or she's the type who needs inotropic support or ventilatory support. In short, she's a hospitalized patient who needs an ICU care. We know we are heading towards DIC. How do we pick it up? We can pick it up by looking at the CBC with low platelets, a raised PT and APTT showing that the coagulation profile is abnormal, a dropping fibrinogen, especially below 100, which is a high risk for bleeding, and a rising D-dimer. A D-dimer is always high in pregnancy. It's a prothrombotic state because of thrombin generation, but a rising D-dimer augurs poorly for the patient and confirms the diagnosis of DIC. We can also look at various other ways of thrombocytopenia. I'm showing you this graph. I'm just going to wait for a few seconds. I want you to take a photograph of this because it will become easy for you to be able to handle any kind of thrombocytopenia if you have got this chart with you, especially the difficult thrombocytopenias. As you know, gestational thrombocytopenia and ITP can be much better managed, but these will require a specialist to be involved beyond your care. So you'll need to involve a hematologist so that you can look at what's happening and see the specialized management, because each one is different. The first three are managed by delivering. The other two are managed by plasmapheresis and plasma infusion, and the SLE needs high amount of the CAPS, which is the catastrophic antiphospholipid syndrome, and SLE needs high dose of steroids to be given to the patient and followed by delivery. So in severe preeclampsia, HELP syndrome and AFLP, if the delivery is, if the gestation is more than 34 weeks, we can deliver. But if it's less than 34 weeks, we can use corticosteroids. But don't be fooled by it. Corticosteroids have not been shown to improve the long-term maternal and fetal outcomes. So it should be used for a short period of time, just to buy time to discuss with the family, get a system in order so that we can go ahead with delivering the patient. And if the status of the patient is not very stable and the gestation is less than 34 weeks, we must talk to the family and get the cesarean section done as fast as possible, because that's the commonest mode of delivery in these patients. I'm sure you'll be taking care of the blood pressure with magnesium sulfate and other antihypertensives. Corticosteroids can increase this blood pressure, therefore you'll have to keep changing your medication based on the blood pressure on the steroids. If it's a TTP or an HUS, TTP especially, then we can do a therapeutic plasma exchange where we can buy time, try to bring up the platelets as much as possible, and if the patient is stable and the fetus is viable, we can still continue on plasmapheresis. Antiphospholipid antibodies sometimes can be catastrophic, causing a significant prothrombotic state, but sometimes can be milder, giving rise to only thrombocytopenia. Don't be fooled by it. This thrombocytopenia doesn't cause bleeding, and actually causes recurrent thrombosis, especially of the placental and decidual vessels. And that's why it has been associated with recurrent pregnancy losses. And generally such patients do very well on aspirin, steroids, and also with low molecular weight heparin if the platelet count is more than 50,000 especially. I've used it as low as 30,000 also. Sometimes we have to give immunoglobulin to just take care of the antibodies of the antiphospholipid syndrome and keep them quiet by an anti-idiotypic mechanism. Towards the end of my presentation, can I just give you some practical points? Just look at the automated CBC smear examination. You confirm that the platelets are low and that they are not spurious or clumped. A good hematopathologist or a pathologist will tell you that. Then look at the past reports. If the past reports show that the platelets have been low, then you must consider either ITP or macroplatelets. How do you differentiate between the two? Really nothing. You can't differentiate between the two, but you can take a history. Macroplatelets usually come from the northern belt. Patients who are coming from Jammu, Kashmir, Bihar, Uttar Pradesh, and Paschim Bangla, and Northeast. Generally, they have a genetic condition which some of them have a macroplatelet syndrome. Mind you, ITP and macroplatelets, when the platelet count is good, especially above 50,000, you don't have to intervene. You can just observe them. But if the ITP shows drop in platelet, then as I discussed, we may have to intervene. If, however, the past reports are normal and now the platelets are dropping, most likely it's going to be a gestational reason for it. If the platelets are low, look at the coagulation profile. If the coagulation profile is normal, you must ask your hematopathologist or your friendly local neighborhood hematologist to look at the smear for microangiopathy, that is the schistocytes. Now, if there are schistocytes, you're dealing with hypertensive disorders, you have to be careful. In the event that the coagulation profile is abnormal and the platelets are also low, start thinking of DIC. So I think this is the easiest, simple, practical approach that I can give you in order to sort of find out what's happening. If you can add to this a liver function test and a creatinine, that will help you to pick up HELP syndrome and will help to pick up even TTP-HUS. In terms of platelet count, many times I'm asked how do we use the platelet count in order to do procedures or deliveries during pregnancy. So if the coagulation is normal, I assume a platelet count is of less than 30,000, based on what is the clinical picture, we may need to treat such patients and we may need to give them either steroids or immunoglobulin, or if there is bleeding, then platelets. Generally for steroids, we counsel them well because it does have certain side effects. And that's why if they can't afford, only then steroids. If it's between 50 and 80,000, we allow the patients to undergo vaginal delivery, and we must tell you that the methodology of delivery would be on obstetric indications rather than hematological. Between 30 and 50,000, it's a critical decision. We really don't know what to do in this situation. If you have got time and we need the platelets to come up for delivery, then we will use one of the methods that has been discussed to bring up the platelets so that we can undergo vaginal delivery. However, if we need a higher platelet count, as in spinal epidural anesthesia, some people say 50,000 is enough. Some people say 100,000 is needed. So the jury is out on that. So somewhere between 80 and 100,000 should be good to be able to do spinal epidural anesthesia and go in for a cesarean section. By the way, we've gone in with much lower counts for cesarean section because for us, it's very easy because the whole hemostasis can be controlled by the obstetrician on table. And that's why we see that it's a very effective way of being able to take care when the platelet counts are very low. At the hospital where I work, we've taken patients for cesarean section even as low as 30 and 50,000. But of course, with general anesthesia, we don't use epidural anesthesia at that time. And we had beautiful results and we had no one bleeding as such, other than if it was an obstetric cause of bleeding. So this is the kind of platelet count that would be needed to do. Many people ask me that if you want to do a cerclage or some procedure during pregnancy, then most of the times WHO or most of the RCOG guidelines all say that a platelet count of 50,000 is enough to do such procedures without a problem. The only need of a higher platelet count is for spinal epidural anesthesia. So I'm going to conclude by saying that thrombocytopenia in pregnancy usually evokes fear in an obstetrician. A thorough history and physical examination, especially the blood pressure, helps to rule out most of the other causes than gestational thrombocytopenia. So a past history of low platelets, either macroplatelet or ITP, and if it's normal, a dropping platelet during pregnancy will bring up the other hypertensive disorders as a simple rule of thumb in your management of patients with thrombocytopenia. I would strongly recommend that you do a CBC, see that someone looks at the smear, do a creatinine, liver function test, LDH, PTPT, PTPDT, fibrinogen, ANA. Most of the times, if you do this panel, you will diagnose most of the events that we have discussed just now, right from gestational to spurious, to ITP, to hypertensive disorders, to DIC. If there is no antecedent history of thrombocytopenia, platelet count of more than 70,000, generally this patient is gestational, which is seen in 70% of cases with a recovery post-delivery. You don't have to involve anybody. However, the platelets start dropping below 50 or there is a pre-existing history of thrombocytopenia, think of ITP as one thought, and you may have to discuss immunoglobulin and steroids so that they are ready for that expenditure which takes place. A platelet count of 50,000 is adequate for most procedures except LSCS. We would prefer cesarean deliveries or ITP for ITP and GT only as per the obstetric indication and not as per the platelet count. But if you want a higher platelet count, then we can intervene and bring it up. Please remember, in the practice, you don't have to get a normal level of platelets. Don't aim for 150,000. You need to get it up to at least 80 to 100,000 so that all your procedures can be easily handled. Once the delivery takes place, many of the times the platelets will rise on their own. So let's not be too gung-ho about trying to make a normal level as such, and this has to be explained to the patient and her family. Non-isolated thrombocytopenia is my worry, and that can create the problems. And if you do the investigation which I highlighted above, most of the times you can pick it up, and the starting point for the antenna is a drop in hemoglobin or bleeding events or the patient starting to have ecchymotic patches on the body. You know that we are heading for trouble, and such patients are better in hospital than outside hospital. Such events will need additional intervention with the help of a hematologist and intensive care and other persons needed along with it. I thank you very much for your attention, and I'm happy to take more questions, but I'm sure in the panel there'll be a lot of other issues that will be discussed. Thank you.
Thank you, Dr. Abhay Bhave. It was an excellent presentation, and wonderfully you have, as an obstetrician, we daily face this issue of a severe PI, a patient who is transferred, who is already in a subclinical DIC with a hematuria being there, and then we want to induce this patient, but then at certain time when they come in midnight or some certain issues where the facilities are not available, you just have to probably do a bleeding time and clotting time. Does it hold true right now in modern obstetrics in such situations?
Thanks for asking that question, Dr. Chavan. Actually, we have given up BT and CT. These two are given up in our practice now, but that's a very important question you've asked. Many people still rely on it, and I can tell you my bleeding time on one hand, on the other hand will be different.
Okay.
It depends upon which needle you use, how deep it has gone in, who's checking for the clot, when did you stop checking the clot. So a lot of, it's very operator dependent, and today's world we can't be dependent on an operator because the operator changes as per duty. So we need a test which is more robust, which is reliable, rapid, reproducible. The 3 R's of a test: rapid, reliable, and reproducible. And therefore, we have shifted to a coagulation test. I have not discussed about TEG, but in our previous discussions with obstetricians, I've been very keen that if you have got a thromboelastogram, a machine which gives you an answer in about 20-25 minutes as to what's happening in terms of the coagulation profile, whether it's coagulation related, whether it's platelet related, whether it's fibrinolysis. It's a beautiful graph which comes up, but everyone doesn't have it. Hospitals do have it. If you got it, it's a fabulous way, because PT, PDT, fibrinogen will take at least 2 hours for you to get the reports. By the time the patient has bled significantly and you don't know what to replace. And TG is a much faster way of looking at it and can give you an answer as to which component should you first ask for.
Dr. Bhave, I have a question.
Yes, sir.
Olden days we used to do Weiner's test and modified Weiner's test. All they are obsolete now?
So most of these tests have got obsolete because at that time they had their value because we had nothing else. And it was I'll say not a loose correlation, but it was a correlation to find out how to go about things and how to approach, but it never told us the deeper levels of pathophysiology. With the current availability of the tests that we have, certainly it's changed the way we manage. And I'm sure all of us together have saved more lives by having these investigations in our hands and doing timely intervention and timely blood components, judicious component, the right component for the right patient in the right amount. That has happened because of all these tests that we've got. So yes, we are thankful to our peers and scientists who have given us such fabulous tests that can make us look good in front of the patients.
Thank you, Dr. Abhay.
Dr. Niranjan, can I just ask a question? Is that possible?
Yeah.
Abhay, gestational thrombocytopenia, now we see it fairly common. When would you actually get alert? When the count drops below 1 lakh and you do a hand count also and it's dropping below 1 lakh, or how would you look at, what are the red flags over there?
So that's a great question, Dr. Pandit. My thinking is that it has to be a combination of clinical events and the platelet count. And I'm assuming that the platelet count has been seen by a competent pathologist or a hematopathologist to confirm that indeed that platelet count is so. Right. Now, once your platelet count starts dropping below 100,000, that's something that we have to worry about, because it could drop very rapidly also, or it might remain over there. If there are no other symptomatology, blood pressure is fine, and there are no proteins in the urine, there is no palpable organomegaly, lymphadenopathy, there is no infective etiology, then we know that this is most likely going to be gestation. Therefore, my thinking is gestation more a diagnosis of exclusion. So your question is right, that how should we look at gestation? We should rule out the other causes before we say don't worry, it's gestational. And the level of platelet which you have asked me, I would say that even as low as 70-80,000, we have not reacted, because that's enough buffer for us to intervene if it drops further. But between 100 and 70-80,000, we start doing some more tests, which normally you would not have done as an obstetrician. I think you should be asking for those tests, such as, a liver function test out of turn, a creatinine out of turn, an LDH out of turn, which is, these are normally not in your ambit. You would not have asked for it. But if you can ask for these, then at least we know what's the trend. So suppose at 100 it was something, and at 70 it is something else. It tells me a trend, because otherwise I don't have a baseline to compare. So that's why we have said 100, so that you start thinking differently. And by the time they come to 70, it will be referred to us and we'll have a baseline to compare. So it makes our job easier. And that's why this discussion that please do more tests below 100, especially as a talking further.
Thanks.
Can I ask?
Yes, ma'am.
Actually, recently we have had a patient whose count was only 20,000 throughout the pregnancy. We gave her so many platelets and everything. We gave her immunoglobulins, and she was asymptomatic. And finally we labeled it as immunological, but she never rose beyond 20,000. Rather, it came down to 10,000, 8,000. So what do you say in such cases? It was really a dilemma with us.
Thankfully, there are not too many of these cases, and hats off to you for managing such a patient, because they can give you nightmares, absolutely, because they can bleed anywhere, anytime. And how much ever you have counseled the patient and the relatives, it's always that you've not been able to handle it. So these are called as refractory patients, and provided there were no other reasons that we discussed, then yes, you will call it as an immune or immunologically mediated thrombocytopenia. Generally, if you throw a higher dose of steroids, and if you can use dexamethasone in this situation, because it improves the integrity of the blood vessels also. So your chance of bleeding at a lower platelet level is also lesser if you use dexamethasone. And you'll use it towards the later part of the pregnancy for fetal lung maturity. But if you can use it a little bit earlier, that might be beneficial. If you've not used immunoglobulin, please use immunoglobulin.
No, we gave her immunoglobulins and we used Dexa. She finally delivered, and after delivery, now she's okay. So, I mean, it was really difficult to manage.
Pregnancy itself is a prothrombotic state. It just consumes platelets. We have to look at other causes. There are 3 more drugs or 3 more things that you can do in such a situation. You can add azathioprine. It's an immunosuppressive agent, and that's safe in pregnancy in the 2nd trimester onwards. You can also consider rituximab in the 3rd trimester to bring up the platelets. And finally, if the platelet count was low to begin with and now it's lower, we know that this girl is going to now go back to a low platelet. You can do a cesarean splenectomy also. So sometimes the splenectomy helps because you have to take care of this girl to be able to take care of the child in the future. If she keeps low, she's more in hospital than outside. Who takes care of the child? So,
Sir, I would like to interrupt you.
Sorry.
There are many questions. I'm sorry, but there are very many questions, sir. Everyone is so much knowing and want to know. Like there are 2-3 questions. I'll just take 2 or 3. Thank you, all of you. I will start with my own case. She is now day 10-11. She somehow last Monday she came and she had a very difficult situation. She delivered. She had an accidental hemorrhage. Then she went in pulmonary edema, etc. And then DIC. Ultimately, we gave her FDPs, etc. And even fresh frozen plasma. Somehow she was diagnosed as sepsis, but we monitored her. We got her out of all these things. We gave her the higher antibiotics. Today is day 10-11, and her platelet count is still. She's post-delivery, post-LACS, and her platelet count is 37,000. So obviously, we write a call as an obstetrician. We always, when we are in a multidisciplinary hospital, we try to take opinions. We don't deal on our own because there is a medical department, there is hematology department, and so do we give her now platelets more or do we wait? Because the guy who has told us not to give her any platelets now because probably it has to come endogenously from her own thing,
Yeah. So this is a situation where the patient has come out of DIC, and first of all, congratulations to you for bringing her out because these can be very difficult situations. Mortality can be high, but you brought her out. If she is not bleeding from anywhere, urine is clear, her blood pressure is good, she is not on multi-system organ support, then you should leave her. There is no additional advantage of giving platelets to people who are not bleeding. But remember, this is a situation where platelets are getting consumed. Her own is getting consumed, plus whatever you're getting is also getting consumed. So you're just exposing her to someone else's blood and the risk of allergic, immunological or infective disorders because of the platelet transfusion. So here, judicious non-transfusion will be the preferred attitude unless there is breach in the mucosa in the form of bleeding, then you are duty bound to give platelet transfusion to her. Many times the platelets will slowly come up on their own. Don't forget, a surgical site will consume the platelets for healing. Once the healing takes place, the platelets will come up over a period of time. Keep a watch on the coagulation, especially the fibrinogen. Keep it above 200, otherwise there's a risk of bleeding.
So they have written on the paper, sir, if it comes down less than 20,000, then only to consider. So I want to ask your opinion whether there is a lower cutoff limit in this case post 10 deliveries, 10 days of a section.
That's a great question. So you have a complex medical surgical situation over here where a pregnancy has terminated in a surgical event which has been associated with another medical event of DIC. There is no cutoff. It's a clinic bedside decision that you have to take along with the people who come on rounds that day, and they decide whether it's worth giving. I would not even bother to give her 20,000 if she is very stable.
Her total count had gone to 45,000 and they were expecting that there is a pus collection in the pouch or Douglas, plus it was in the splenic and below the liver and in the sub-diaphragmatic space, and they were in a dilemma actually, but I was very sure I am not going to do any re-exploration for this because that time her platelet count was 37,000.
Was an ultrasound done at that time to look for any?
Yes, ultrasound was done, sir, and they found a pouch or Douglas, but that is where a very important decision was made, and I am right. I'm thanking everyone, whoever at that time what my head thought, and we did not explore her, re-explored her, because then that would have been a worse scenario. Somehow she's pulling on.
Yeah, she is stable, leave alone. Yeah.
Yes.
Give it time, nature heals.
Yes. And there are many questions, sir. So we will get back to you. It's already been covered. And don't worry, we have this video coming back in the next day, and we will surely, showcase you that video. Everyone will love. And I want to tell you, all of you, you're all great. You're amazing, because now we have got more than 2,500 viewers, and they have gone through Dr. Abhay Bave's lecture, and we are all excited, and we are all waiting for Dr. Suchitra Pandit, Shanta Kumari Madam, Pratima Mittal Madam, and our Guru of Gurus, Dr. Sarogi, to be with us. So I would like to share the screen now, and I hope I can connect, and we will go for the panel discussion. I hope someone can tell me that I am on the current slide, and can you see this now? Please acknowledge
Yes.
whether you can
Yes.
see. Yes. I have all big stalwarts. We are all amazed to see them today. They have given their valuable time to be present with us. Dr. Suchitra Pandit, Dr. Shanta Kumari, Dr. Pratima Mittal, Rajendra Sarogi sir. And I would like to share here with you. I don't know why this is not moving. Yes, sorry. So this is the case I would like to share with you. I hope you can see this was a young lady, and she's married since 6 years. I hope everyone can hear me. She's third gravida, and she's 30 weeks pregnant, registered at Sion Hospital. She came with the usual cheap complaints of easy fatigability, weakness since 1 month. I want to tell you that at Sion Hospital we conduct 14,000 deliveries a year, and we cater to the largest slum area of Dharavi, Antopil, Govandi, and Kurla. So she had all these symptoms of, anemia, which you can find out, but there were no other bleeding, PV, or any history of jaundice. Basically, she was registered with us for the 4th month of gestation. She visited us regularly, received 2 doses of tetanus toxide. She got also hematinix, but she did not complain of gastritis. Obstetric history briefly: 2 full-term normal deliveries, 2.5, 2.8 kg, no other morbidity, no NICU admissions, and that time also she was registered. Patient had no contraceptive history. There was no significant past history, family history, or dietary history, being a vegetarian. On examination, what we found was that she had pallor at 34 weeks. There was no icterus, there was no clubbing, no cyanosis, no edema feet. General condition, all the vital parameters were fine, but only the pulse was little tachycardia, 98 per minute, and per abdomen it was a uniformly enlarged globular uterus, and it was corresponding approximately to 28 to 30 weeks size, and fetal heart sounds were normal, so there was nothing to worry. So I would like to come back to Dr. Suchitra Pandit, madam. Madam, now you have this case in front of you. Can you guide us regarding investigations to be done? Does she require any admission? And what other specific investigation you would like to do? But before that, you can always talk about classification of anemia. The mic is yours, madam.
Okay, so first of all, I think let's start off with if you want me to answer the classification first, usually we talk of an acute blood loss and a chronic blood loss. And then we talk about whether this anemia is absolute or relative. Now, relative anemia is seen in pregnancy or in situations where people are, in the astronaut, can have, or athletes can have a relative anemia. But what we are really concerned about is the absolute anemia. And absolute anemia, you have either a decreased production or you have an increased destruction. Now, if there's a decreased production, you're looking at probably a defective stem cell proliferation. Could be because of aplastic or an interruption of the DNA synthesis, which is seen in megaloblastic. Megaloblastic could be because of a B12 or a folate, or what we traditionally see, an interruption of hemoglobin synthesis. Now, this is what we see more commonly, the iron deficiency anemia, thalassemia. And then, of course, the typical interruption of development of the precursor cells, as seen in anemias which are associated with the chronic renal disease or an endocrine disorder. But When you're looking at the second group, which is an increased destruction, the increased destruction could be either intracorporeal or an extracorporeal. Extracorporeal is what we see particularly in cases of mechanical type hemolytic neuremia or microangiopathic hemolytic anemia or infection. I think infection is something which is very, very common, particularly malaria. Chemical or physical agents, which we have seen time and again because of certain drugs, which could be toxins, which could be even an acute burn indication, and then the autobody induced, which is the antibody mediated. And these are again all extra corpuscular, but the intracorpuscular ones could be because of a membrane defect, like hereditary spherocytosis or an enzyme deficiency, which you've seen in G6PD, or the globin abnormality, which we are concerned about because here you see the sickle cell anemia and sometimes the hemoglobinopathy, and the paroxysmal nocturnal hemoglobinuria, which is again acquired, which is seen in cases of the the classical PNH. Again, when we are looking at anemia, we should be talking about nutrition, because nutrition is very, very common in India, and this is classically either there is a protein deficiency, because most of the times in vegetarian diets and the wrong time of taking the food or the wrong mixing of foods, then the vitamin deficiency anemia, which is there because of the B12, because of the B6 of the nicotinic acid, or the mineral deficiency, which is seen in iron, copper, cobalt, or even selenium. And then when we are talking of anemia, what ICMR has said, fine, you know about the anemia being there, but you must also know the typing of the anemia. So in the typing of the anemia, you're looking at the typical microcytic hypochromic type of picture, which is seen in iron deficiency or which is seen in thalassemia. Then second type you have is the normocytic normochromic. This is again commonly seen either in an acute blood loss, or it is seen in certain types of hemolytic anemias, or even in a renal disease or bone marrow failures. And then you have the macrocytic. Macrocytic, again, when you're looking at an MCV of more than 95, you're typically the megaloblastic anemia or the non-megaloblastic. So when we look at the peripheral smears, this is what we get. And as I said, the ICMR says all this is, you can understand, but you must talk about what is mild, what is moderate, and what is severe, because this is clinically useful for us. So anything having a hemoglobin of less than 5, we typically take it as a severe anemia. Between 5 and 8, when the hemoglobin is, we talk about a moderate anemia. And mild is basically anything which is above 8 right up to 11. So they talk of 12 grams hemoglobin as ideal, but anything above 11.5 in the first trimester, you can take it as about 11.5. And then in the second trimester, it tends to drop down because of the physiological hemodilution. So this is classically the different types of classification that we are looking at. But in this particular patient, Niranjan, she's got easy fatigability, she's got pallor, and the symptoms are highly suggestive of anemia. I would definitely like to do a CBC, obviously the hemoglobin, the platelets, and look at a complete hemogram. And if it is in a public hospital setup, sometimes doing a complete hemogram becomes a little difficult. But if you can do a complete hemogram, which includes the MCV, the MCH, the MCHC, and particularly the serum ferritin, because that's important to know the iron stores. And I would definitely advise people to do a peripheral smear, because peripheral smears then can type the anemia, and you can actually label it as whether it's normocytic, normochromic, or macrocytic, or whether it is microcytic. In my practice, because I'm now in the private setup, I'm also including the test for thalassemia, HB by HPLC. But in the public setup, if you're doing a peripheral smear and then deciding which patients need a further test, that would also be adequate. Urine routine, stool routine, and blood grouping are absolutely imperative. I would like to do a thyroid also in this case. I'm sure it has already been done, but she's talking of an easy fatigability, so I would look at that test also. Thanks, Niranjan.
Amazing, madam, the way you have conducted the whole classification of anemia and the description which you have given and the way you have classified is amazing. Thank you, madam. You have enlightened us, and it was so useful that you gave the whole scenario of how to deal with such situation, and especially when you have a patient of anemia. And then we have Dr. Shanta Kumari with us. Madam, we call anemia a preventable problem. Why are we still talking about it in 2020 as a potential killer disease in pregnancy?
Yes.
For years together, there are various programs, madam. I am asking you because you are our representative in Foxy and in FIGO, madam.
Thank you, Niranjan. I think me and Suchitra and in our school, we used to read something about the 5-year plans. I'm sure all the seniors, now the younger generation would not have read about the 5-year plans.
Correct.
In all the 5-year plans, they used to write anemia, they used to talk about ANC, maternal health, but it was always only those statements which were made, and the ideas and the implementation were actually not in an as effective as they are now. Because maybe at that time, about 60 years, 50 years back, we really didn't have a concept of what was wrong and how to tackle the problem. When I look at statistics, we find globally the anemia is so huge. Forget only developing countries. Globally also almost 25-30% anemia is there. And when we look at our country, we find some of the studies have shown as high as 70 to 90% of anemia in pregnant women, and some states have about 40 to 50% anemia. And there are some studies in schools, in adolescent children, again as high as 70 to 90%. And we have found definitely that anemia is a major contributor to all the problems. And that is the reason why, unfortunately, still anemia is there. And it's multifactorial. It could be the nutritional deficiency, it could be some worm infestations, infections. Now, in our own country, infections like malaria and tuberculosis and some other, maybe in some time we'll be say COVID also, when it becomes a chronic epidemic other than a pandemic, that also all the infections are contributing to the anemia. And that is the reason why, in spite of everything, we still don't have an answer. And anemia is not there only in the underprivileged, where we may think the lack of food or good diet. We find anemia is there across the socioeconomic status. Maybe it could be the diet, it could be the multifactorial. We don't know. We actually have to see whether there's an environmental factor, whether all this, the pollutions, all the food which you are eating, which are having full of all this toxic chemicals, whether they are also contributing to the anemia. And of course, women have the issue when they're already low on their hemoglobin, and cyclically when they lose blood. So that chronic anemia state is continuing. And that is the reason now India, along with the Swachh Bharat, our government is looking into various factors to improve the anemia in our women. So that is how we need to look at it, Niranjan. It is a public health problem, because more than 40% incidence of anemia is there. It is not only a small clinical problem. So this pandemic of anemia should be treated with an iron hand. So then
oh my God. Madam, that iron hand from the Iron Lady of India, and it rhymes very well. And thank you for your insight on this issue. It's a very, very bigger problem, and there are three main reasons for this.
I think, Niranjan, if I can see, now the government has initiated a Swachh Bharat. See, that Swachh Bharat may sound very simple, something clean India, but that also is linked to this huge problem of anemia burden, because that will reduce the infections, that will reduce the worm infestations, and that in turn can actually improve the health of the people. So these are all interlinked public health issues, which we should target.
So, madam, I agree with you. With hand sanitization more often, we will have less worm infestation and maintaining of hygiene, and we are preparing food ourselves rather than eating from outside food. So probably that worm infestation will also not be there, and the way we are cooking at our places, and so enthusiastically we are consuming it. So I think that makes a lot of difference but this is only going to be temporary, I hope.
I-
But as you said, there are various reasons. Yes, madam,
Maybe
continue.
this pandemic has taught people also what is very important is to improve the immunity by having lot of fresh vegetables, fresh
Yes.
fruits, and vitamins and minerals in their diet. So probably all this will add more iron, more vitamins like vitamin C, which will help in iron absorption. So all this indirectly also it will help in the anemia correction, which will go a
Absolutely.
long way.
Thank you, madam. It was a wonderful discussion with you, and you're really like a man or a lady in Foxy have really dealt. We are going to deal it very strongly, and I'm going to come back to you soon with all the government programs which you will be talking to us. So we go to the next speaker from North Zone, and it's none other than Dr. Pratima Mittal, madam. Madam, now we already know that there is anemia. It's like an epidemic which is there. But I want to know from you and the viewers, the nation also wants to know what maternal anemia causes to the fetus and the offsprings, and is it going to be having a significant health risk later in the life? And in your personal experience, if you have seen an anemic woman, especially a severe anemia, as commonly can you find in your practice, and what do you attribute these trends for? Dr. Mittal.
Thank you, Dr. Niranjan. Thank you for inviting me on this platform. It's really a privilege to be with all these stalwarts. And coming to my question, when the direct effect on the fetus is generally not, there is no direct effect, but it has been seen that basically the effect will depend on the severity of the anemia as well as on the gestational age. It has been seen that low birth weight babies are commonly seen in the patients with anemia. The low birth weight can be due to prematurity as well as from the for these small for gestational age babies. And secondly, it can be poor Apgar score is noted at 1 minute. Besides that, there is a fetal distress which is more common in these cases, and also it has been seen that the fetal stores, when the maternal stores, iron stores are very poor, so fetal stores in the first year of life are very low in these cases. And behavioral disorders, cognitive dysfunctions are commonly seen when these babies grow up, and besides that, developmental delays are noted. And one thing which it was really important, and it was a news to me also, that it has been seen that adult onset hypertension in these babies later on in life has been associated with severe anemia in pregnancy. I don't know, that only one paper was there, but it has come to our notice that adult onset hypertension is also seen in these babies later on. And coming to your next question, that is the severity. Yes, definitely the number of severe anemia cases have reduced in our setup. Initially, we used to get, I don't have the exact percentage, but initially we used to get about 20% of these cases as severely anemia with hyperproteinemia, generalized anasarca, such a difficult end failure. But now in my HDU, still we had about 7% patients who came with failure or in, severe anemia. But when we looked at the nation picture in the nation, I saw that in HMIS data in 2008 and 2009 said that the incidence of severe anemia is 11.2%. It was 11.3%. While now in 2017 and 18, it has reduced to 3.29%. And it is varied in different states. Again, the variation in different states is due to various reasons, like poverty, socioeconomic status is definitely there. But besides that, it has been seen that, in Nagaland and Kerala and the states, this is as low as less than 2%. But in other states, Madhya Pradesh, Andhra Pradesh, Telangana, it is more than 10%. And the reason it has been said that in Telangana, the B12 deficiency is more common. And in Andhra Pradesh, it was attributed to the, worm infestation, which was more common. In some states, it has been attributed to the rock salt consumptions, which is, which diminishes the iron absorption. In other places, it is the fluoride, excess of fluoride in water, which is also leading to less absorption. And besides that, the incidence is increased. You have said incidence is increased by, what do you think? I think the main reason is our national programs, because they have led to detection of anemia, free availability of iron, and the testing. Previously, we were not doing testing. When we do testing, we tell them the patient you are anemic, then they are more compliant to the treatment. I think that is the main thing. Thank you.
Thank you. Thank you. So wonderfully explained by you. What is the reason for having severity of anemia and why there is an increase in the incidence of anemia? You're absolutely right. There is a lot of awareness, and the Ministry of Health and Family Welfare also is doing a good job for more detection of anemic patients, and we are having all those schemes. But we will get back to them very soon. Thank you, Dr. Pratima Mittal. And now we go to Dr. Rajendra Sarogi, sir. Sir, what has changed in the last decade in the treatment of anemia, especially in pregnancy? And what do you feel, as per your clinical experience and knowledge, that when an anemic patient should be hospitalized and she should get admitted? Your expert comments on these 2 points.
Thanks, Neil, for involving me. Now, first and foremost, in this particular case, if you look at it, last delivery was 1 year back. She is already about 30 weeks. That means she has conceived during probably lactational period. So she was anemic right from the beginning. And on top of it, she may be lactating still, and anemia is still there. Now, what has changed in last decade in the treatment is number of children have reduced. That is one. Spacing of the children is being done. Now, let's try and understand why iron is required during pregnancy. If you look at the entire 9 months of pregnancy, 300 milligram of iron is required by the fetus and the placenta. About 500 milligram is required by RBC mass. About 200 milligram is the natural loss occurring through GI tract and through skin and through genitourinary system. So overall requirement becomes 1000 milligram over a period of 9 months. First 3 months we don't give any iron. So over a period of 6 months you will realize that daily requirement of iron is roughly 6 milligram per day. If you look at the absorption of iron from iron tablets or from body, it's always 10% of the total absorption. So per day you should consume minimum 60 milligram of iron from second trimester onwards. Now your food generally contains about 6 to 8 milligram of iron, not 60 milligram. That means one thing is sure, that you have to give prophylactic iron to all our ladies starting from second trimester of pregnancy onwards. That is one thing clear. Now, what is this prophylactic iron? WHO in 2016 recommended that you should give 60 milligram of iron along with 400 microgram of folic acid from second trimester onwards as prophylaxis to all the patients, all pregnant ladies. And if she is anemic, then give 120 milligram of iron along with 400 micrograms of folic acid till anemia gets corrected. This is in the early part of pregnancy. While Fox's recommendation in 2017 is, if pregnancy is less than 30 to 32 weeks with anemia, give 100 microgram of iron, 100 milligram of iron along with 500 micrograms of folic acid till anemia gets corrected. And once anemia is corrected, then you can start with about 60 milligram of iron with 500 microgram of folic acid till delivery and then again postpartum. This is the way you have to treat the patient with anemia. Now, as far as Foxy is concerned, Foxy considers anemia as less than 10 gram% as far as Indian population is concerned. If hemoglobin is between 10 to 10.9 and she has come early in pregnancy, you can definitely give her iron tablets and folic acid. If over a period of 2 months you realize that there is no increase in hemoglobin, it may be that patient is not compliant, or it may be that patient has diarrhea or malabsorption syndrome. In that case, you can think of giving parenteral iron in the form of FCM or iron sucrose. Similarly, if patient has come between, say, 7 to 9 gram, in that case also you can, if she has come early, again you can give folic acid and iron tablets. After 2 months, if you realize that she has not responded well, you can go ahead with IV FCM or IV sucrose. If hemoglobin is less than 5 gram% or 6 gram%, That is when, if she is not in labor and has come before 32 weeks, definitely you can go ahead with IV FCM. If she has come late in labor, or she has come in labor, or she has CCF or any other complication, that you may think of giving PEG cell volume and other resuscitative measures which are required during pregnancy and labor. So that part you have to keep in mind as far as patient is concerned.
So I think you have nicely explained regarding not to have iron in the first trimester, but surely from second trimester onwards we have to start iron capsules along with folic acid, and you have to find out whether there is any nausea, gastritis, or issues of constipation. But surely even now the health schemes which are there of the government, and they surely recommend that ferric carboxy maltose can be given to antenatal patients. So that has, I think, sir, changed in the last decade.
Yes,
10
correct.
years.
Correct.
That's
Earlier we used to give intramuscular iron injections in the
yes.
form of Vilcofol or Jectocos. Now that has gone. We used to give iron dextran also in those
Yes.
days. Now all that has gone, and we rely more on IV iron rather than on intramuscular iron.
Absolutely, absolutely. So we have to understand all these things, and depending upon the severity. But mind you, all this thing has to be done prior, before you go ahead. You give all these medications, but first confirm what is the diagnosis. Confirm by doing all the hemogram as suggested by Dr. Suchitra Pandit, madam, and then you have to have certain special investigations. If you are in a tertiary center, try to analyze and try to find out whether it is microcytic, macrocytic, dimorphic, and we have obviously a hematologist there who has already explained on thrombocytopenia, and Dr. Sarogi and Pratima Mittal also has nicely explained what is the reason for this anemia which is happening, and how you can, give them management protocol for a pregnant woman. And I now, yes, sir.
FCM and sucrose are basically meant for iron deficiency anemia and not for anything else.
Yes, that is the point to be noted. And I come to Dr. Abhay Bhave. Abhay Bhave, sir, are you there? Please join us. What is the role of a hematologist in the management of anemia in pregnancy? Do we refer always to a hematologist, and when do we refer? So please opine on that. And the most important question is erythropoietin. What is the place in this situation of a pregnant woman with anemia? Is it safe to use? And does it have any therapeutic advantage? The mic is yours, sir.
Thank you very much, Dr. Chavan, and I'm very thankful and very impressed with the discussion of anemia that is taking place with the panelists. I think if anemia in pregnancy comes to a hematologist, I think in a way I see it as a failure of our system. I think in a way we have failed the community, that we've not been able to impress upon them that keeping the hemoglobin good. And I love the idea of Dr. Shanta Kumari about Swachh Bharat Abhiyan. I think internal Swachhata is also very important. And one of them is to have a Pandurog Mukta, especially Maharashtra or Bharat. So therefore, I feel that if we were able to take care of the girls when they got married or when they're in the marriageable age and impress upon them what a good hemoglobin is, then we would not be facing anemia in pregnancy. The fact that they have developed anemia in pregnancy, other than reasons which are related to pregnancy alone, but if they have come as an anemic girl into pregnancy, I think that is a failure of our system. We have not been able to take care of them adequately. My role in the management of anemia is usually when my obstetric colleagues have tried medications and the hemoglobin has not improved to their liking. That's where probably my role comes in. And here what I do is that I try to analyze the simple reasons for anemia. We start from an algorithm from the basic, a good CBC with indices, see what the indices show. We divide it into hypo, micro, macro. In hypo, macro, beautifully Dr. Pandit has said, we look for iron deficiency, thalassemia, and there is anemia of chronic disease also as part of it. There used to be lead intoxication, now it is not as common. And there is anemia of sideroblastic anemia because, say, antituberculous medicines or other medicines which are taken or as part of a genetic disorder. But commonly in a hypochromic microcytic, we've got either iron deficiency or thalassemia as your main players in the game. Macrocytic is B12 and folic acid deficiency. For a hematologist, it's very easy if I see the peripheral smear that I can come to know immediately what is happening. And I love Dr. Pandit comment that if I was in the public sector, usually I just look at smear, and most of the times an answer is obvious. If it's a hypochromic microcytic, I want to give them a therapeutic trial of iron therapy, whether it's oral or whether it's intravenous. That depends upon the patient's compliance, and then see whether there's a rise. I would not wait for 2 months. I think with oral iron therapy or IV iron therapy, I'll redo my hemoglobin at the end of 3 weeks. Even if I don't see a rise in hemoglobin, if I'm seeing a change in the indices, the MCV, MCH is getting better, which are very good indicators that we are on the right track, I'll continue with that line of treatment. In the event nothing has budged or the hemoglobin has dropped further, then I'm worried about this. Then I'll start looking for other causes. I may even look for thalassemia if it's not been looked at. And here I'd like to tell all my obstetric colleagues, please do a thalassemia study, a hemoglobin electrophoresis, because if the girl is thalassemia minor, and the husband is also thalassemia minor, then there is a 25% chance of the child being thalassemia major in each pregnancy. And this is something you don't want a child of thalassemia major to be born. And this should not catch you as a surprise later on in the pregnancy that you did not do the hemoglobin electrophoresis. So please, I beseech you, I urge you, that we must be able to do hemoglobin electrophoresis in our patient. But I might just tell you that do the hemoglobin electrophoresis after you've given enough amount of iron. Otherwise, sometimes that hemoglobin electrophoresis can come as a false normal value if there's severe iron deficiency. So as a hematologist, I might want to tell you, treat the iron adequately and then do. So if you say that if the patient is say 20 weeks pregnancy and you can't wait for 3 weeks of oral iron therapy, just do the husband's HB electrophoresis. If the husband's HB electrophoresis is fine, then you don't have to worry about the thalassemia status of your patient. At the most, the patient will be minor or will be normal. The child will be minor or normal. So we're not worried. So there are ways of looking at this. But if the patient is thalassemia minor, please look at the hemoglobin electrophoresis of the husband. For that, we have to do the patient's value. You do so many tests, please include HB electrophoresis. So that's the next thing I would want to do if the patient is not responding. So non-responding patients are the commonest referral to me. It could be because of improper iron compliance. It could be because they want me to say that take IV iron therapy. It could be because that we have to look at thalassemia and other causes of anemia. By looking at the smear, we pick up the dangerous causes of anemia, including the hypertensive disorders induced, that is like HELP, ATP, HUS, DIC, AFLP. We can pick that on the peripheral smear if the clinical situation demands. In terms of erythropoietin, I speak with a lot of trepidation and anxiety because erythropoietin is not commonly in the domain of the treatment of anemia in pregnancy. However, there is a huge movement to avoid blood transfusions, and quite rightly so, because we don't know what we are giving through blood, which infections, which allergies, which immunological intolerance. Therefore, it's in your and my interest to prevent a transfusion going into a young girl. We don't want to be saddled with an HIV, hepatitis B or hepatitis C later on in life, and the finger to be pointed at us saying that, why do you give blood when you could have managed something else? Now, what's that something else? The something else usually iron, usually is oral iron or IV iron. It could be vitamin B12. It could be something else, and that something else could be erythropoietin. So typically in patients who are refractory to anemia, to iron therapy, refractory anemia where there's no obvious reasons found, then erythropoietin is one such molecule that can be used. I've used it commonly in patients who are already anemia of chronic disease. So I've got patients of SLE who have recovered, young girls who want to get pregnant and are pregnant, post-transplant, post-bone marrow transplantation, post-renal transplantation. They've got a persistent anemia because of anemia of chronic disease. They want to get pregnant. They don't want transfusion. They want to bring up the hemoglobin. Iron has not helped, and erythropoietin could be one way of doing it. There are different protocols. The protocol which I have followed is what I use in hematology, 10,000 international units once a week, because taking this erythropoietin 3 times a week is not very compliant in the patient. The patient doesn't want to be poked subcutaneously 3 times. So once a week, 10,000 units is what I give. And I give it for at least a period of 3 to 4 weeks. And even if the hemoglobin is not dropping, that's great news. Please don't give erythropoietin intravenously. Last 2 points will be on erythropoietin, that please see to it that it does not contain benzyl alcohol, because that can cause fetal distress and fetal issues. So be very careful. And with erythropoietin, see that you do at least a 2 weekly analysis of the hemoglobin to see if it's rising. A rising hemoglobin will allow you to continue. If the hemoglobin is dropping further, then as Dr. Sarawagi sir said, that we may even have to consider blood transfusion to such patients. And the cutoff of 5 and 6 is rather arbitrary. It is about how the patient is symptomatically. Most of the pregnant women who come to me for anemia, I see them symptomatic already at 7. So I have not seen too many women coming to me with a much lower hemoglobin. By the time they have come to 7 and they are dyspneic, edema feet, unable to carry out their work, they end up getting transfusion. Last point on transfusion, please see to it that you use, if it's possible, nucleic acid tested blood. I think we owe it to society. Give them the most safe possible blood that can be given. If you've got a blood bank close to you which does nucleic acid testing, it reduces the window period of infections. Use that. I use 3rd generation filter to see that unnecessary neutrophils do not enter and cause reactions. CMV negative blood is in the West. We don't get it. 96% of our population is CMV positive. So getting CMV negative blood is out of question. And irradiation is a contentious issue. So I give nucleic acid tested wherever it's possible and filtered blood. I can't do irradiation always, and I can't use CMV negative blood. So that's my thought process on erythropoietin, and if it doesn't work, transfusions.
Thank you.
Dr. Bhave, can I ask one question? Do
Yes,
you
sir.
have to give iron along with erythropoietin?
Yeah, that's a great question. So, so what I do is I look at the ferritin value and the transferrin value. You'll notice that in anemia of chronic disease, where you are ultimately going to use erythropoietin, if you do the TSAT, transferrin saturation, if that is near 20-25, the ferritin, let us say, is 100. Dr. Pandit has told us that ferritin is a very good molecule, and I fully agree with her because I want to do ferritin in all my patients. If the ferritin value is below 50, the odds ratio of this being the cause of anemia is 1.8. And if it's below 30, the sensitivity and specificity is reaching 80%. And if it's below 15, it is 98% sensitivity and specificity. So if the iron levels are low, then addition of iron to the erythropoietin is helpful. But in our situation, you've already given iron. But even if the ferritin is above 50 and closer to even 100, and the transferrin saturation is less than 20, you can still use IV iron with erythropoietin. Why am I saying this? I'm saying this because in anemia of chronic disease, there is a pro-inflammatory state. Pregnancy is anyway pro-inflammatory. So the ferritin can come falsely high. That's why even if the ferritin goes to 100, and some of the publications are even for 300, but as long as the T-sat saturation is down below 20, you can still consider giving IV iron. So I would say less than 20 T-sat and up to 100 ferritin, I would still want to give IV iron, not oral iron. I'll give IV iron with erythropoietin.
Thank you, Dr. Abhay.
Yeah, sorry, go ahead.
Yeah, I know we are all excited about your talk, and there are many remarks here, many comments. There's one doctor from Agratala. She has said that what an excellent talk, Dr. Mamta Singh, and wonderful discussion being going on by the senior TOG. And what better to have such a wonderful hematologist who is supporting this cause. And we as Foxians, we have been discussing, that is the beauty of Foxy. This association is always talking and working relentlessly for so many years to fight anemia. But yes, it is still a long way, and we will take this more aggressively. I am sure Dr. Shanta Madam in her tenure will be working very hard with government agencies, and all Foxians will be involved. So on behalf of my fellow colleagues and all those doctors, I would like to thank all of you. But still we have got few more questions, so we will be going back to the questions. This is the open-ended question to all the panelists. When was that last anemic case which you had to see in an emergency, which you faced, and how did you manage this situation? Be kind enough to be brief. Thank you.
Niranjan, can I talk about
Yes,
this?
yes.
Yeah, this happened when I was at Sion Hospital. I was working there. That particular emergency, a patient, 24-year-old, gravida 3 para 2, walked in. She actually walked in to the emergency room in the labor ward, and she was about 34 weeks pregnant. She wasn't exactly breathless, but you could see a general apathy on her face. And the reason she came in was because she was leaking. So the residents saw her and they rushed, and they called me, ma'am, this patient looks very, very pale. It's impossible to classify what that pallor is. She could be 3, 4, 5, but we don't know. So anyway, we admitted her, but the lady wasn't concerned at all. She was we asked her, why didn't you actually come regularly for visits? So she said she'd just come in from a small village in Bihar. Her husband worked as a laborer in one of the building sites, so that's how she had come. And the first visit she had at around 24 weeks. At that time, her hemoglobin was already 7. She was advised iron. She took it sporadically, so she didn't really bother when she got transferred to Mumbai. Only when she started leaking did she come to the hospital. So now when we examined her, she did have some baseline Krebs. So probably she was already in a failure. We quickly sent off all the necessary bloods, including the hemogram, and the hemoglobin came out to be 4.5. So which was a little scary. She was already leaking. We started off with antibiotics, but we also ordered for 4 packed cells. In those days, fortunately, we had moved over from whole blood to packed cells. We gave the packed cells, but in this particular case, we also gave her IV Lasix because we were worried about the basal Krebs. And by that time, she had already started contracting. And you'll be surprised to know that her delivery was relatively uneventful, but here we were all scared because, of the 4 grams, 4.5 grams hemoglobin. But by the time the 3rd packed cell was given to her, she was fully dilated. She dilated very, very fast. She had a relatively uneventful delivery. Of course, we did the Amstel, the active management of the 3rd stage. She did bleed, but it was not more than 250 cc's. So that was actually a saving grace for us. Once she delivered, she was very relieved that everything is over. She didn't query about the bloods. We gave her the 4 units of packed cell. We admitted her, we kept her in the ward. And 3 days later, we were talking to her about, we wanted her general condition to improve. We also did the vitamin B12. Surprisingly, there was also very, very low vitamin B12. And we gave her an injection. And then we discussed about, further, family planning, tubal ligation. And by that time, the hemoglobin was about 9 grams. We decided to go ahead with the peritoneal sterilization. But before she went home, we also discussed with the hematologist, whether there was anything else that we should do. She was thalassemia, normal. There was no problem. The only thing was it was a pure iron deficiency along with the B12 deficiency which was causing this problem. And the patient went back home, after her sterilization. So we were very, very happy. In those days, we did not have FCM. Otherwise, I would have definitely given her FCM before she went home. But we gave her the iron tablets. We made sure that she came back for a follow-up, and fortunately, everything went off well. But it was a scare for the residents and for us.
Thank you, madam. Dr. Shanta.
I think Suchitra has given a very good example, but see, I worked in a private medical college at a corporate hospital. But even in that private medical college, which was catering to the old city, I have seen severe anemias, not only in pregnancy, generally I have seen a woman who actually came with hemoglobin of 3 grams with a gynec menorrhagia. And as she told, she was absolutely cool and not at all worried. Incidentally, when we did the CBP, and of course we managed it, it was not an antenatal case, it was a gynec case.
Yes, ma'am.
So I think we have to be very vigilant and try to pick up. And I actually hear my colleagues, all my friends in GMH and other hospitals say they're getting women sometimes at 2.5 grams hemoglobin, even in this day of the era. Last minute they were telling, 2.5. That's not this thing. They had to. You can imagine how the situation is, and
yes,
with COVID also. So
I think that point has to be noted. We are not only talking about in pregnancy, but surely we get cases like this in gynae and having menorrhagia with AUB.
Puberty menorrhagia. I've had a young girl, small. Just menarche. Her hemoglobin was 4 grams.
Yes,
absolutely.
Last week, I also received one lady with 4 grams. She was in pregnancy, 20 weeks. So I think I don't know, we still get those once in a blue moon, but surely a severe anemic case. Dr. Pratima, madam from Delhi, what is your case which you saw last?
I think we have same experience as Dr. Suchitra has pointed out, same type of case, but we are getting it quite often, I think 1 case a week, we are definitely getting 1 case per week, and less than 4 grams with CHF, and with severe anemia, we give them oxygen, treat, manage CHF, and then
Yes.
sometimes I have seen that even when they come to from severe anemia, when they are brought up to moderate anemia, then they don't respond to iron itself. In those cases, even injectable iron they don't respond to. And in those cases, when we have given them injectable B12 and folic acid also, then only they show the response. So it is mainly these, all the deficiencies combined together which we get. But mostly with CHF, generally we get a case of severe anemia less than 4 gram with CHF many times.
Absolutely. Dr. Sarogi?
Yeah, we had a patient transferred at Dr. R.N. Cooper Hospital as severe preeclampsia at 36 weeks. BP almost 200 by 120 diastolic. We took her up for section. Hemoglobin done at that time was somewhere around 9 gram %. Post-operatively, she looked very pale after being shifted to the ward. We repeated hemoglobin, it turned out to be 5 gram. We had to give Paxil volume. She went home well, but before sending her home, we gave her FCM and then we sent her home. What I want to stress here is any case of preeclampsia, eclampsia, remember one thing, you have hemoconcentration and the actual hemoglobin may be 10 gram, but in reality hemoglobin is actually 8 gram %. So you have to be very vigilant as far as cases of preeclampsia and eclampsia are concerned. We could save this lady and she went home fine, no problem.
Thank you for each one of your cases which you have described. Still, we have to go a long way, and we will try our best how we can improve the situation of anemia. So I go back to Dr. Suchitra Pandit, madam now. Madam, do you recommend hemoglobin electrophoresis as a part of a routine antenatal care panel? And who should have this test done? This has already been answered by
Yes.
Dr. Abhay Bhave, but
Yes.
we want an
Niranjan,
obstetrician view, madam.
Yes. Niranjan, I have completely included this in my routine antenatal panel at the first visit itself, or even patients who are in the preconception counseling, because I'm working in a private sector now.
Absolutely, yeah.
When I left Sion, Dr. Mamta Manglani, I was working at the Thalassemia Center, and she had made such an impact on all of us at that time that please start doing this test. Don't restrict it only to the Sindhi community or the Parsi community or somebody with a history of hemoglobinopathies. Do it for everybody, because today, now which we see, there are so many mixed marriages. We have had a Sardar girl marrying a Keralite, and she was absolutely normal, but there was a history of hemoglobinopathy in the family. Whereas the other way around, you see a Catholic girl having hemoglobinopathy because her grandmother was Gujarati. So with all these mixed marriages, I think it's a part of a routine test. And HB by HPLC, I'm sure Dr. Abhay Bhave will agree, it's a relatively cheap test. It should be included in the armamentarium for doing this. But where it is not possible, at least a peripheral smear and a hemogram could be done, because then when you're looking at the typing of the anemia, you look at the level of the MCV, there at least you can have a high index of suspicion. And as Abhay very beautifully pointed out, the reason for doing it in the first trimester is because you can actually do a prenatal counseling. If the girl is, thalassemia tray, you check out her husband, because you don't want to have a kid with a thalassemia disease. I fully very happy that Abhay brought this out, because I was going to talk about it. And I think it's only when the HP by HPLC method is not available, that's why you can go for the standard, chromatographic technique. But today, most of the labs in Mumbai or in bigger cities have the HB by HPLC. So yes, Niranjan, to just sum it up in a nutshell, I'm doing it for all pregnant women and pre-test counseling.
Niranjan, can I add something?
Yes, sir.
There is something like Menzer index, which suggests that you should do indices, and the ratio between MCV and RBC concentration, if it is more than 13, it suggests that it is an iron deficiency anemia, and if it is less than 13, it suggests thalassemia. Similarly, RDW, if it is more than 14, it suggests iron deficiency anemia, and if it is less than 14, it suggests that probably you are dealing with a case of thalassemia. So in our indices also, we can suspect and subject these patients to hemoglobin electrophoresis.
Dr. Niranjan, can I make a comment also?
Yeah, please, please.
So on indices, of course, we can do it. But I'll just tell you that, as a hematologist, sometimes we get cases coming to us where you've done the thalassemia test and the hemoglobin A2, if it was high, above 3.5, that was considered as thalassemia minor or thalassemia trait, but you got a normal value. Now, in this situation, when they are referred to us, I look at 5 things. A low hemoglobin, if your RBC count is normal or high, MCHC is normal, you still could be dealing with a thalassemia, and you could do an alpha thalassemia test, especially if the RBC count is high. So what is called as refractory anemia may be an undiagnosed alpha thalassemia. One last point. I can still diagnose a beta thalassemia trait, which is called as a silent A2 thalassemia. So you are going by A2, we are all going by A2. What if the A2 is 3.2? Cutoff is 3.5. Your MCV is low, MCH is low. RBC count is normal or high. That is unusual for an iron deficiency. That has to be on the lower side in iron deficiency. The moment it goes higher, you're still dealing with a beta thalassemia. Don't be fooled by it. Please ask for a genetic testing. And sometimes you'll pick up the common genetic mutations for beta thalassemia by doing that test. So I'm just saying that Dr. Saragi brought out a beautiful point by looking at the indices. I also look at the indices for this and I combine it with the thalassemia study. If my suspicion is still high, I will go for the genetic testing because its implication is very wide, including medico-legally for a thalassemia major child not to be born.
Yes, I think that we have understood the importance of all these thalassemias, sir. And Suchitra, thank you for bringing it to the fore. And
yes, madam.
Niranjan,
Yes, madam. We have got only a few minutes now because we have already shot more than 1.5 hours of the program, madam. This is regarding Dr. Shanta Kumari. How should one judge the response to oral iron therapy? Would a rise in hemoglobin be expected?
this was answered by Dr. Bhave in his talk, if you remember,
Okay.
3 weeks.
Okay.
So it's not in, I think we need not cover it again.
Okay, madam. So we go to the Dr. Sarogi, sir. Dr. Pratima Mittal, madam, we will come back to you soon. We will get back to you after Dr. Rajendra Sarogi. Sir, when we should consider parenteral iron therapy and what are the safe practices that one should follow in giving parenteral iron?
Good question, Niranjan. First and foremost, parenteral iron means intramuscular or IV.
So
now,
both.
The days of intramuscular iron has completely gone.
Okay, sir. Okay.
We basically stick to IV iron. Now remember, IV iron, it can be in the form of IV dextran, which we used to give once upon a time, which has gone now. Then has come IV sucrose, which is still being used, and then you have IV FCM. Now remember one thing before I forget. The biggest disadvantage of FCM iron is only one, that you are not giving other micronutrients along with it. Now when we give ferrous tablet, iron tablet, we add folic acid, we add B12, we add other things. But in FCM or IV sucrose, we are not giving other micronutrients. So you should supplement with other micronutrients. That's very important. Second thing, when it comes to giving IV sucrose or IV FCM, IV sucrose does require sensitivity test because it is known to cause reaction, while IV FCM does not cause any reaction and it is quite safe during pregnancy. Both the ions can be given only from second trimester of pregnancy and not in the first trimester of pregnancy. IV sucrose is available as 20 milligram per ml, 5 ml ampule, so 100 milligram. It can be diluted in 100 ml of normal saline, never Ringer or dextrose or DNS. It has to be normal saline. You give initially 25 ml, that means 25 milligrams slowly over a period of 15 minutes IV. And once you find that there is no reaction, you can finish off rest of the things in another 15-20 minutes. IV FCM also same way, but it does not require any sensitivity test. You can straight away add 15 milligram per kg body weight of IV FCM. If the weight is less than 35 kg, you don't give more than 500 milligram at one go. If the weight is more than 35 kg, you can give 500 milligram or up to 1000 milligram. If the weight is more than 70 kg, you can go up to 1500 milligram at one go. Remember one thing, if you want to repeat, it has to be done after a week and not immediately.
Sir, as you very rightly put it, I think all of us do understand that when we are giving the sucrose or the FCM, we are always supplementing with folic acid and B12. Most of us are supposed to write. So I think that way the patients are quite okay. Our gynecologists are dealing it quite properly. Most of us, we tell them you write any folic acid B12 combination. So they are getting it. And the most important thing is we really don't have, though iron sucrose, the only issue was repeated doses and that was it. But as per se, we didn't have much reactions or anything, even in our, I think, gynec practice. And gynecologists are better in using this parental iron than the other physicians and all, because we know we have like day in and day out, we deal with anemias. So our people are more experienced with giving parental iron, as you rightly put. Thank you.
What is more important is in Purpurium, invariably at Cooper Hospital, I had made it a rule to give them IV sucrose before we discharge the patient. And it was very useful in proper involution of the uterus and breastfeeding, and breast milk also was of a good quality and quantity. So I had made it a rule over there to give IV sucrose to all the patients at Cooper Hospital.
Yes, sir.
Niranjan, can I just add one?
Yeah. Yes, please.
Just one more thing, because we talk so much about FCM now and all of us are in love with that FCM molecule. I would still like to reiterate one point here, that please should know the thalassemia status, because if a patient is thal minor, then, or even sickle cell minor, in those cases it will be an iron overload. In these patients, you can give FCM if the ferritin levels are very low. But if the ferritin levels are normal, please be very careful. Otherwise, in an iron deficiency anemia, FCM is a great molecule, free from dextran, free from the side effects, and less of anaphylaxis. In fact,
so I think all of you have covered the FCM part and also all the details and what are the government scheme, which is there is Abhiyan which is going on. Yes.
That is, we have got this Anemia Mukt Bharat, which is a very important initiative, public health initiative by the Ministry of Health and Family Welfare. Now you have to understand the most important are the 3 T's: test, treat, and talk. We are now test, treat, and tracing for COVID. You have to test, treat, and talk. So talk about anemia to all the women, all the children, all the family members, all the men in the family, to see that the women are safe. Even boys are also anemic. So that is very important. And the most important is this particular public health problem. It is the modification is going to the beneficiaries. It is accountability is there at the same time, and then the supply chains. So all that the government is doing a fantastic job, and I'm sure that we will conquer anemia.
Thank you, madam. Dr. Sarogi, kindly discuss the deworming therapy in iron deficiency anemia.
See, what's more important, why deworming is important, because there are 2 types of worms which can cause anemia. One is Ankylostoma duodenal, that is hookworm. Another one is Schistosomia. Schistosomia is also known to cause bloody diarrhea. Now, Ankylostoma duodenum, single ankylostoma will cause a loss of 2.5 milligram per kg. It will cause a loss of 0.26 ml of blood per day per worm. That's equally important. If there are 50 worms, you can understand how much of blood loss is occurring per day. The best treatment is albendazole 400 milligram single dose or mebendazole 100 milligram. However, we have levamisole 2.5 milligram per kg body weight, either in single dose or you can give 2 doses. Or you can give parenteral palmoate again in dose of 10 milligram per kg body weight in single dose, or you can repeat it after about 48 to 72 hours. So you must do deworming at least in India.
Thank you, sir. Now we go to the last question, and we have after that a rapid fire round from the audience. Dr. Pratima, madam, we discussed all these things about anemia and how to treat them, but obviously there are some cases which are severe anemic. So when do you demand to give a blood transfusion?
very clear indications. Patient, if she is less than 36 weeks, less than 5 grams, we have to give, or she is in failure, then we have to give. But if she is more than 36 weeks, if her hemoglobin is less than 6 grams, we have to give, or we are preparing her for cesarean. A very clear-cut indication, especially in failure, we have to give. If severe anemia with failure, we have to transfuse blood.
If she's with severe anemia in labor, then
also, sir, we have to, keep the blood ready, give her Lasix, and of course, we have to transfuse if the patient is, come out of the failure. Only then we will transfuse.
So thank you all of you. And with this, we will end our panel. And I would like to go back and stop sharing my screen. This is the Anemia Free India, which was the Gujarat model. And now where FCM was used. And now it is a part of the Anemia Mukt Bharat. And there was 914. Yes, madam.
I can't see myself on the screen.
Dr. Pratima madam had told Telangana and AP as high for anemia. Madam,
okay.
There are a lot of WhatsApp I'm getting from a lot of people in Telangana on my telephone. Telangana statistics are not that bad. Andhra Pradesh, there are the Far East, then the Haryana.
I'll share with you that
they were all very apprehensive and worried, and immediately I was getting, so why Telangana has been.
I will share the reference, madam. It is from HMIS data, which is saying about this from the they're comparing it with the 2008 statistics and 2018 statistics, and
it has touched the heart of this thing, and we won't let any such matter
it is from the government statistics. It is the HMIS data which has said so.
I agree with you, Shanta. Actually, if you look at the global prevalence, it is 38.2%. These are the latest figures.
Yes, sir.
Kerala has 32.8%, while Northeast states, particularly Assam, has 69.5%.
That's what, because malaria and all endemic infections are the main important cause.
Overall Indian rate is 55.5%.
How much is Telangana, sir? You have that statistics, please. You can tell.
I don't have it.
I have.
How much, madam?
I'll tell you. Just a moment.
Yeah, because everyone are sending me messages, so I thought let us anyway. And Niranjan, because we need to be, because if it's like that, we have to be more proactive, and we'll see that.
Yeah.
Because our health system.
Telangana, it is 8 to 10% severe anemia, and Andhra Pradesh it is 6 to 8%.
So it is very less, madam. Then why did you quote it's high?
No. I said it is varies state-wise, and in Telangana, I said that way, that it is around 10%. It is varied because of the vitamin B12 deficiency.
Okay.
It is because of that habits, diversity.
We were worried that we were not taking care of our women.
Yeah, and in AP, Andhra Pradesh, it is because of the, worm infestation.
Yeah,
that is what it was given, the causes. I was not saying it is less, more in Telangana.
I thought it is more, so we got a bit worried.
I was giving the answers that why it varies according to the geographical situation.
Thank you for the clarification.
Amazing panel discussion going on, and I'm very happy. A lot of points have come. Thank you, all of you. I have no words to say, but we will go to the rapid fire question round of our panel discussion. Wonderful discussion occurred. Dr. Pratap Kumar has sent a message here, and he is very happy to hear from you. Ferric carboxymaltose is commonly used when treating second and third trimester pregnancy, and it is quite safe, and you might have to require fewer repeated application due to higher iron dose with each administration. Thank you, Dr. Pratap. This is an excellent presentation regarding hematological disorders and pregnancy by all of you stalwart. This is Chandar Lata. We in central India do sickling in first visit, and also do husband sickling and SOS hemoglobin electrophoresis, so that we could know about the baby being sickle cell or as a pattern. This is Dr. Pallavi Ingle sharing her thoughts, and Dr. Shanta, there are many messages for you also, and it's really nice. Dr. Bhave, you have been an excellent speaker, and there are various questions which are there. I will take one by one. Just let me go out of this and go to my Gmail. Thank you so much. 1 minute. In the meantime, You can ask any questions to Dr. Bhave. Dr. Bhave, thank you for being there with us. Are you there still with us?
Yes.
Yes. So you can just tell me what are the things.
While you're doing that, I'll just reiterate Dr. Pandit's stand that while ferric carboxy maltose looks very attractive and something that can be given, two things please just remember: see that you have a ferritin level, because in case there's a reaction, you have to have a reason why you gave that ferric carboxy maltose. And number two is that please give the ferric carboxy maltose carefully, because sometimes there are reactions. So you should know what to expect in case there's a reaction. Suppose you don't have the facility, it's always a worry.
Sir, ideally, can I give a small suggestion to all our friends? If we have to give parent lion, please don't give in the night or evening. Better give in the morning.
Wonderful.
Morning and in the setup where the patient is taken care, because don't let a good molecule fall into bad mouth.
The incidence may be very less, but that one is enough to create a problem.
So you take and use a proper brand. Sometimes you take substandard molecules. Sometimes you get so many things. So you have to be very careful on the brand and the quality of your parental lion.
Absolutely agree.
Very, very important.
Dr.
For all
I want to know what is the role of sucrosomial ion nowadays. They talk so much about sucrosomial ion.
So, apparently the idea of sucrosomial ion was that it could absorb despite hepcidin being increased. As you know, pregnancy is a little bit pro-inflammatory. The hepcidin goes up. If hepcidin goes up, it tells ferroportin not to absorb iron. So you get an artificial iron deficiency because of hepcidin. So thinking now is that if you use sucrosomial ion, then you will overcome this hepcidin, because the absorption is three different mechanisms. One is the standard intracellular, one is paracellular, and one is through some cells in the lymphatics called M cells. So your absorption is good, and they have a pyrophosphate, ferric pyrophosphate core. So that binds to transferrin very well. So as a result of that, the transference of the iron molecule to the required site, that is the liver or to the bone marrow, is good. And that's why you can overcome the hepcidin. You can give by different methods. So sucrosomial ion has got that concept. And then we have to do a study to see how well it's working in our country.
What about ferrous ascorbate? Ferrous ascorbate.
So ascorbate, fumarates, all of them actually are good. It all depends upon how that patient's gastric acidity handles the bridge or the link between the salt and the iron. So some people tend to break that bridge very quickly in the stomach, causing gastritis. So that's why people don't take, which is the advantage probably something like sucrosomial ion has. Something which something which has a core covered by something, a calcium core or a calcium covering is there, then that helps to prevent the iron from being released in the stomach and go. So anyone who makes that will deliver much more iron into the duodenum where it is absorbed.
What about gastric bypass patients? Which iron do you recommend?
Because I've seen that oral iron doesn't work very well. So
they require IV.
Once in 3 months, I just tell them, take IV iron of your choice. I specifically agree with Dr. Shanta Kumari that take a proper iron, a proper compound molecule, but just take it and be happy. Because oral iron you can take, but they get a lot of side effects.
Sir, now I got these questions here. I will just have a rapid fire round.
Niranjan, can I ask one question?
Yes, madam.
I just want to ask that if we give excess iron, we have seen that we are talking of always giving, iron deficiency. Excess iron. If the patient has taken too much of iron, what does it cause?
You're asking me. Okay.
Yes.
So Dr. Mittal, thank you. Generally, if you're taking oral iron and it is excessive, most of the iron will be stored in the mucosa of the intestinal cell, as a ferritin molecule called the mucosal ferritin. And it will be shed off during the next shedding of the endothelium of the intestine. Some amount it will go through ferroportin into the blood. So that excess iron, body will see to that it regulates very well through ferroportin. Okay, and then there are enzymes DMT3-1 and DCB enzymes which will see to that you don't absorb excess also. Now there are some people who got a tendency in the intestine to be able to absorb excessively, and they are the ones who are like hemochromatosis. So there are certain associations of molecules which absorb iron over and above what is required and transport it beyond the ferroportin into the blood. Those are very rare. And excess iron becomes a bigger problem when it is IV, but then there is no regulatory authority taking care of it. Oral iron, still we have the intestine who can handle. IV, no one can handle it, goes excessive. And therefore, again, Dr. Pandit's earlier comment, check the ferritin before we give iron. If you've crossed more than 100, really there's no advantage of giving more iron. Ferritin of 100, no advantage.
Actually, it has been seen in the babies that they have more chances of convulsions. Neonates have
Okay.
more chances of convulsions if you are given extra.
Thanks. Okay, thank you.
Okay. Dr. Bhave, one more question to you. Changes in hematology in COVID positive persons. What have you encountered?
Oh boy, from pregnancy, thrombocytopenia to COVID. Okay, so we are seeing a lot of changes in COVID affected patients in terms of blood. Let's start with CBC and then go to coagulation. In CBC, we are seeing a drop in hemoglobin. We are seeing an absolute lymphocyte count which is going very low. And the ratio, if it is more than 1.5 between neutrophil and lymphocytes, we are seeing that it is associated with a more difficult period of COVID infection in the patient. We are seeing a drop in platelets. Fortunately, two things. The platelets generally don't go below 30 or 50,000. We are not seeing a very big dip. Number two, it is not being associated with bleeding. These are the blood changes in terms of hemoglobin, WBC, and platelets. And some asymptomatic people, we are not even seeing a drop. So this is all happening in those who are more symptomatic, who are moving from home to hospital and from hospital ward to ICU. This is the trend which we are seeing. In terms of coagulation, there are more changes. The D-dimer is going up, the fibrinogen is going up, and there is a kind of
ferritin is going up.
The ferritin is going. These are all inflammatory reaction. So today, the way we look at it, in COVID, there is an unhealthy nexus between infection, inflammation, and the COVID virus. All three together are causing what we call as immunothrombosis. As part of the inflammation and infection, we are setting up a coagulation cascade which is causing a clot. And because of that clot, the clots are microvascular clots. They're not big clots which are occurring in big veins. They come much later. It's the small clots, especially in the lung, which are creating the problem. And therefore the oxygen goes down, and that's why they're calling it happy hypoxia death. The patients are not that symptomatic. The oxygen level is going low because there are now lots of microthrombi in the pulmonary alveolar. There are leakages in the pulmonary vessels. Fluid is leaking out, and for the patient becoming a little bit dyspneic, but still able to manage. And then the oxygen starts dropping, but the patient is stable. And when it suddenly drops 70, 80, we get all problems. So there are
absolutely, wonderfully you have explained very nicely, sir.
Actually,
Dr. Shanta, and then we will end the show.
See, we have been listening about this ferritin levels going up and all this, but I think most important in this COVID pandemic is all of us have the responsibility to correct anemia in patients. So use telemedicine, telecounseling, and even social media or television media to improve the hemoglobin of all the anemic women and men. That is very vital in our fight against this pandemic also.
Comment over here that I made a video which is called NAID, that is non-anemic iron deficiency, and Dr. Sarawgi actually mentioned this in his discussion. So we have many people whose hemoglobin is 11, 12, but they still be iron deficient.
Yes.
When they go into pregnancy thinking everything is fine, over a period of time the hemoglobin drops. So everyone should get iron therapy unless the indices are absolutely normal and the ferritin level is good. Then you can wait, but then you have to keep sorting out because not everyone, most of them would develop some form of iron deficiency. And unfortunately, many of our girls are already iron deficient. They may not have iron deficiency anemia, but they have an iron deficiency state that is called as non-anemic iron deficiency, which needs iron therapy. Otherwise, you'll land up in trouble in the second, third trimester, hemoglobin drops, and then you have to give them IV. See, IV is a cost. It may be safe and all that, but it's a cost. And I think we owe it to our community to give them a much simpler form of oral iron when there are 100 molecules available. Why not use them and see that they don't develop severe anemia in second or third trimester?
It's not. See, we deal with women more than you, sir. So what happens is they have passed through that phase of where the oral iron so by the time they reach us, we are forced to give parenteral. So though FCM is a good molecule, sometimes it may be a little cost effective, patients can't afford. Don't leave your sucrose, please give the IV iron sucrose also.
My earlier comment that I think we have somewhere failed our community. We're not able to express and impress upon them that hemoglobin is so important.
Not we, sir. The whole public health system, everyone. It is not only doctors. It's the political will, commitment, and the social this thing.
to the common man.
Yes, this is not should not be a discussion for us.
So for us also, we are also important to be
Public.
discussed, but also outside.
Yeah, public health domain.
Agreed.
Okay, wonderful discussion I am having. Dr. Sarogi, this is the last question to you. Why do we need to finish the FCM 500 milligram drip in 6 minutes? Dr. Kaushal Chundawat.
Yeah. The basic idea is iron molecule, if it remains in saline for longer period, more than about 15 minutes, not 6 minutes, 15 to 30 minutes, it becomes an iron, and only Fe ion going in the body in IV form can be dangerous for the patient. That's why you should never allow it to remain for more than 30 minutes when you give IV FCM. So
Thank you,
give iron fast.
Thank you, sir. Thank you, Dr. Suchitra Pandit, Dr. Shanta Kumari Madam, Dr. Pratima Mittal, and Dr. Abhay Bhave. We have crossed more than 2,500. Wonderful discussion. There are many questions which are still unanswered. But I'm sure I will call you back for the second part of hematological disorders. And madam, all of you have to promise me today, please be there, because there are many, many questions which are unanswered. And we will just take some audience questions then. Because there are many, many people who have joined in. And Dr. Bhave, you will have to also join in for those technical questions. And from hematological point of view, you're all COVID warriors. In spite of your busy schedule, you have been there with us. And thank you, all of you, with your gem of knowledge and pearls of wisdom. We will see you soon. And thank you all. I would like to thank MCure, Inventia Division, Science Integra, Mr. Subbu, Mr. Srimon, Session, and all the viewers who have been part of this program today. And of course, Foxy Medical Disorders in Pregnancy, Dr. Komal Chavan, who has brought this program to you. We will be in touch with you. Don't forget to join us on 25th when we have an international speaker from Israel, Anat Gafter. She is from Hematology Department in Israel, and we are going to hear from her. And Dr. Shanta Kumar is going to join us then. Thank you so much. See you soon.
Thank you, Niranjan. Thanks on behalf of all the panelists, and thanks to Science Integra.
Thank you. Bye-bye,
Thank you.
everyone, all the listeners.
Thank you.
Everyone.